Hi there, this is an animated analogy to explain how upper and lower motor neuron facial palsy causes differing patterns of facial weakness. The facial nerve has sensory, motor, and autonomic functions, but for this analogy, we will focus on its main function, which is to innervate the facial muscles. When we decide that we want to move our face, the first part of the pathway is activation of the motor cortices. This is represented by the red and blue handles, representing the right and left motor cortex. From the motor cortex, there are upper motor neurons that go to the facial motor nucleus on either side. There are contralateral corticonuclear tracts, which go to the opposite facial motor nucleus, and ipsilateral corticonuclear tracts that go to the same-sided facial motor nucleus. They are named corticonuclear tracts as they travel from the cortex to the brainstem cranial nerve nuclei. Sometimes they are called corticobulbar tracts, but technically this means fibers traveling from the cortex to the medulla, which was previously known as the bulb. The corticonuclear tracts are represented by the red and blue ropes connected to the handles. To make the analogy less distracting, the ropes going to the right side have been made lighter in colour. Looking at the analogy, you can see each side's motor cortex sends ipsilateral and contralateral corticonuclear tracts to the facial motor nuclei, which is shown by the green circles. The facial motor nucleus is found in the pons. After the ropes pass through the green circle, they represent the facial nerve. In reality, once the upper motor neurons of the corticonuclear tracts synapse at the facial motor nucleus, they send lower motor neurons that go to the facial muscles. For analogy purposes, this has been shown as continuing pieces of rope. The facial nerve innervates the upper and lower facial muscles. For simplicity, only two are shown. The buccal and marginal mandibular branches of the facial nerve supply the lower facial muscles around the mouth. This is shown by the hooks connected to the mouth corners. The mouth corners represent the risorius muscle, which helps to raise the corners of the mouth to help you smile or show your teeth. It is assisted by other muscles, such as the zygomatic muscles and the levator labii superioris. The facial nerve also innervates the upper face via its temporal branch, where one of the most clinically relevant muscles to test is the frontalis muscle. The frontalis muscle helps you to wrinkle your forehead and is represented by the grey sheet of paper. The blue rope hooked onto the right side of the mouth is under the control of the left blue motor cortex, and the red rope hooked onto the left side of the mouth is under the control of the right red motor cortex. This shows that the ipsilateral lower face is influenced by the contralateral motor cortex. Looking at the forehead, you can see on both sides there are blue and red ropes hooked onto it. This shows that the upper facial muscles have bilateral input from the motor cortices. This means if one side's motor cortex fails, there is a backup to keep innervating the upper facial muscles. We likely have this backup so that if there is a unilateral motor cortex lesion, both orbicularis oculi can still contract to protect the eyes. For analogy purposes, muscles such as the orbicularis oculi and oris and the platysma muscle have not been included, but in clinical practice they will be tested also. Furthermore, the 5 branches of the facial nerve have not been separated out. In summary, the upper face has bilateral cortical representation, and the lower face has contralateral cortical representation only. If asked to wrinkle your forehead and show your teeth, both motor cortices on the left and right become activated. This sends impulses to the ipsilateral and contralateral facial motor nucleus, which together activate the same-sided facial muscles. This is shown by both the blue and red handles being pulled, which pulls on the ropes going to the same and opposite side, which pass through the green circle. The ropes are hooked onto the mouth corners and grey paper, which when pulled, lift the mouth corners and crease the grey paper. When considering facial pathway damage, it is helpful to categorize them into upper motor neuron lesions and lower motor neuron lesions. The upper motor neuron includes the cortex and the corticonuclear tracts. The lower motor neuron includes the facial motor nucleus and the facial nerve. Common upper motor neuron lesions are strokes, multiple sclerosis, and tumours. This is represented by the scissors. Let's imagine that the corticonuclear tracts arising from the right motor cortex are damaged. This means that the right motor cortex cannot influence the facial nerve on either side. The left facial nerve supplying the lower face is normally under the exclusive control of the right motor cortex. As this connection has been cut, the left lower mouth corner drops down. As the left motor cortex and its ipsilateral and contralateral corticonuclear tracts are intact, it can continue activating both sides of the upper face and the right lower face. This is represented by both red ropes coming from the red handle being cut. As the red rope and hook was the only thing keeping the left mouth corner up, it falls. Even though the red hooks have fallen off both sides of the forehead, the blue ropes and hooks are intact, and so it is still raised. The right mouth corner is also held up by blue hook, so it continues to be raised. This means if you ask a patient with a right upper motor neuron facial palsy to wrinkle their forehead and show you their teeth, you will see normal bilateral forehead wrinkling, but they will not be able to raise their left mouth corner. Interestingly, it is not only the motor cortex that innervates the facial motor nucleus. Parts of the brain involved with involuntary emotions, such as the cingulate gyrus, also innervate the facial motor nuclei. This is not shown in the analogy. This means that they can influence facial movements independently from the motor cortex. For example, if something funny happens and you laugh or smile, you don't command your face to make a certain facial expression. It happens automatically. Knowing this, if damage occurs to the motor cortex and you ask them to smile, they will not be able to raise the opposite mouth corner on command. However, if you say something funny and make them laugh, they will now be able to spontaneously raise the opposite mouth corner, as this is influenced by the emotional brain centers and not the motor cortex. This is known as volitional facial weakness with emotional sparing. Because of this, it is useful to have a few jokes in mind. The opposite is also true. If there is damage to the emotional brain centers but the motor cortex is spared, they may not be able to smile spontaneously but can on command. Let's now look at lower motor neuron facial palsy. Common causes are otitis media, diabetes, and temporal bone fractures. If it occurs idiopathically, it is known as Bell's palsy. If the left facial motor nucleus or the left facial nerve is damaged, all the left facial muscles are affected. This means that even though the left or right motor cortex are working fine, they cannot influence the left upper and lower facial movements. There is no problem with the right-sided facial muscles as their connections are still intact. This is represented by the scissors cutting the red and blue ropes at the left green circle. The ropes get disconnected from the red and blue handles, and so they fall. The left grey paper and left mouth corner are not held up, making them drop also. Rarely, you can get bilateral lower motor neuron facial palsy. This tends to be caused by Lyme disease, Guillain-Barré syndrome, or sarcoidosis. In summary, an upper motor neuron facial palsy causes opposite lower facial weakness. A lower motor neuron facial palsy causes same-sided upper and lower facial weakness.